Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I'm your moderator and narrator, Uriel, Neveu, Riley. So we're in section 4, Airway Care. We pick up at chapter 15, page 247. Yes. Peace, YouTube. Highs, heart, love. Welcome. In the middle of page 247, this 42nd edition of this book reading, Post-Intubation Essentials. The immediate concern following the placement of the endotracheal tube is the assurance that the tube is within the trachea. The respiratory care practitioner must immediately inflate the cuff and listen to the chest with a stethoscope to make sure that the lungs are being ventilated equally and bilaterally. Even if the patient is breathing spontaneously, give a few deep breaths with a positive pressure hand ventilator while listening to the chest. You must be positive that the lungs are being equally ventilated. This is written in all capitals. So if the endotracheal tube is mistakenly placed in the esophagus and positive pressure ventilation initiated, the air movement in and out of the stomach may easily be misinterpreted as lung ventilation. The stethoscope should be placed over the stomach to detect air movement in and out. All right, there we go. Again, we're about application. This is the application of it, how to do it. Thank you so much, YouTube, for being here and reading books with us. This is medical information, so we're giving it out to the public for free. We love you. There we go. If there is any question at all, the glottis must be re-exposed and assurances made that the tube is not in the esophagus. If extubated, ventilated, and then re-intubated, and inappropriately placed or non-functioning endotracheal tube is even more lethal than the patient's own poorly functioning airway. Once the airway is assured, the next concern must be the securing of the tube so that the inadvertent extubation will not take place. Use a tincture of benzoin on the face where the tape will be placed aids in assuring that perspiration, secretions, or the movement of facial structures will be less likely to loosen the adhesive. We have found taping endotracheal tubes with a head halter technique extremely dependable. There must be constant reevaluation of the placement of the emergency airway and constant reassurance that there is ventilation of the lungs. This is especially important during the rigors of cardiopulmonary resuscitation and in the early support of critically ill patients. There are usually many people gathered around the patient carrying out various functions. It is the prime concern of the respiratory care practitioner to assure appropriate establishment and maintenance of the airway. All right. Peace, you two. Thank you so much for reading with us and being here with us. It's a beautiful day. Happy Monday. New moon energy is really powerful, right? Here we go. The top of page 248 of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Cricothyroidotomy. When emergency surgical entrance into the trachea is demanded, only the most skilled and experienced of surgeons should attempt an actual tracheostomy. The operative procedure of tracheotomy is difficult and dangerous, even under optimal conditions. The emergency surgical entrance into the trachea is called the cricothyroidotomy. It's very key. That I'll make sure I have that in the description as one of the vocabulary words. The cricothyroid membrane, see chapter 1, is an easy landmark to find since it lies directly below the Adam's apple. The membrane usually lies well above the large thyroid vessels and below the vocal cords. A midline incision through the cric- cricothyroid membrane will allow entrance into the larynx below the vocal cords without interrupting major blood vessels. Any type of tube may be inserted to maintain patency. The advantages of this emergency surgical approach is that the landmarks are easily found under emergency circumstances. In addition, the incision site is well above the area where a definitive tracheostomy would be performed, allowing the definitive tracheostomy to be done electively without contamination. The cricothyroidotomy is a procedure that should not be performed without great concern by respiratory care practitioners. However, the technique must be understood so that if it is ever necessary to save a life, it can be appropriately and satisfactorily accomplished. Emergency airways in cardiopulmonary resuscitation. An essential responsibility of the respiratory care practitioner is to be involved in cardiopulmonary resuscitation. The first priority is to ventilate. The initial attempt should be made with bag and mask or mouth to mouth resuscitation. However, with prolonged closed chest massage or other resuscitative efforts, it becomes essential to establish and maintain an artificial airway. The oral endotracheal tube is the emergency airway of choice. Thank you so much. Lots of yes, Chris. Your highest heart love. Thank you so much, sir. Peace. Yeah, this is the peaceful part of YouTube where we read books and learn from masters. So I'm Master Fitness Trainer Uriel Neveu, and I read these books on this channel to the people for free. And this is thousands of dollars worth of information right here. Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We are now in the 15th chapter. This is section 4 and the bottom of page 248 for those in the replays and in the playlist. Thank you so much for reading along. Highest heart love. All the book lovers community, we love you so much. Thank you for the likes and subs. Emergency airways in cardiopulmonary resuscitation. That's where we're at now. So, okay, here we go. There have been many attempts to develop techniques that avoid the necessity for emergency endotracheal intubation by inexperienced individuals. There is a new method, the esophageal arbiter, which must be given due consideration. Yeah. The authors wish to emphasize that at the present time there has been only limited experience with this device. No absolute statement can yet be made as to its effectiveness. The esophageal arbitrator is schematically represented in Figure 15.9. It is composed of a mass that can be placed tightly around the nose and mouth to provide an adequate seal. The tube itself has a blind end and is meant to be inserted into the esophagus. With the cuff inflated, regurgitation is theoretically prevented, and the possibility of forcing air through the esophagus into the stomach is theoretically avoided. Holes in the tube are present at the level where it lies in the oral pharynx, and therefore, positive pressure placed on the tube will cause positive pressure in the mouth with all other outlets for the escape of air occluded, nose, mouth, and esophagus. The air will be forced into the airway and the lungs. The use of the esophageal arbitrator is entirely dependent upon the assumptions that one, the esophagus is easier to intubate than the trachea. Two, the inflated balloon will seal off the lower esophagus and stomach, avoid regurgitation, and prevent inflation of the stomach. And three, an adequate mass seal can be maintained. Very key. Top of page 250 for those reading along. Thank you so much. I know, Chris. That's how it goes. I mean, we're reading thousands of dollars of valuable information for free on YouTube. So that just comes along with it. Master transmutation is we just keep going. We stay focused. Focused energy vibrates highest. That's what we know. The principles of healing sound, right? So we stay focused. Thank you so much for reading with us. We show the world how to do it too. Because when they come back in the replays, they see, wow, they were right, all that and this and that. They're like, wow, he just transmuted all that energy. That's what we do. And when the mods are in the building, thank you so much, Chris. High is our love. Divine awareness. The greatest potential for using the esophageal arbitrator undoubtedly lies with the paramedical individuals outside of the hospital or resuscitation teams not trained in endotracheal intubation. It may prove a reasonable alternative to endotracheal intubation in those circumstances, but at the present time has not had widespread clinical trials. Animal studies indicate that the esophageal arbitrator does not provide as good ventilation as the endotracheal tube, but does a slightly better job than bag and mask, with the potential advantage of preventing regurgitation, which the bag and mask does not. On the other hand, there may be regurgitation following the removal of the esophageal arbiter, arbitrator. One must be ready to suction, turn the patient on his or her side, and intubate the trachea if necessary. All attempts must be made to prevent aspiration. In summary, endotracheal intubation is the route of choice for ventilation during cardiopulmonary resuscitation. Every effort should be made to train respiratory care personnel in this technique. However, in circumstances where there are personnel with limited training and in mobile coronary care, the rescue units where endotracheal intubation may not be feasible, the esophageal arbitrator may be a desirable alternative to simple face mask ventilation. All right, moving on. Here we go. Down towards the bottom, page 250. Thank you so much. Eyes, heart, love. Limitations of emergency airways. Very key. The oral endotracheal tube and cricothyroidotomy have been discussed as the choices for establishing emergency airways. The oral endotracheal tube is not ideal for prolonged, greater than 24 hours periods because, one, it is usually poorly tolerated in the semi conscious or conscious patient. Two, it is extremely difficult to stabilize since the cheeks and tongue are freely movable. Three, inadvertent extubation is common. Four, to keep the patient from biting on the oral tube, an oropharyngeal airway or some type of block is usually inserted, which causes further discomfort to the conscious patient. Five, vagal stimulation may result from excessive movement of the tube within the pharynx and the trachea. Yeah, that's a big limitation right there, right? So want to take note of that. That's what this section is about. Just being aware of the limitations, right? Hi, so yeah, let's read that again. Five, vagal stimulation may result from excessive movement of the tube within the pharynx and the trachea. Six, it may be extremely difficult to suction because of its curvature and poor stabilization. Seven, it is almost impossible to feed the patient orally. And eight, it is often difficult to attach respiratory therapy equipment to this poorly stabilized airway. The limitations of cricothyroidotomy are intuitive. One, the incision is so close to the vocal cords that it is undesirable to keep the stoma cannulated for any length of time. And two, the incision is usually made under less than sterile conditions, and the chances of wound infection are high. Mm. A cricoid should be replaced with an appropriate airway as soon as possible. Middle of page 251. Non emergency airways. In respiratory care, non emergency airways are defined as those that are essential for placement but are not an immediate life and death concern. This situation occurs under one of two conditions. One, there is already an emergency airway in place, which makes the placement of a more permanent airway less acute. Or two, the placement of the initial airway is elective since the problem is not one of immediate urgency of life and death. Non emergency airways is respiratory care are either nasotracheal tubes or tracheostomies, and are always accomplished by fully trained and qualified personnel. Thank you so much for being here and reading with us. Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Here we go. The nasotracheal tube. The placement of an endotracheal tube through the nose is termed nasotracheal intubation. This is accomplished blindly or under direct laryngoscopic vision. In either case, it should be placed only by skilled individuals. Yes. Blind nasotracheal intubation is indicated in alert patients who are capable of spontaneous ventilation for at least short periods. The nose and pharynx can be adequately anes- anestheti- anesthetized so that the placement of the nasotracheal tube by a skilled individual is a reasonably atraumatic experience. I will be placing this, I will get to it and make sure the vocabulary is super high level. So, I will get to putting it in the details when I it's fully uploaded. So thank you so much for being patient as well with me putting in the vocabulary. It's a lot, and um, I, I do this because I love you and I want the best for all of us. So it's I'm doing it all myself, and I thank you so much for the support on the channel. It isn't easy reading all these books with all these different vocabularies, but you know, that's what allows us to level up. I want to give you this gem right now, just so you know. Check this out. When you do things that others don't want to do, right? Then this enables you to be able to do things that no one else can do. And that's the difference. That sets us apart as masters because we go in and we face and lean into the parts that we may not want to do, but it makes us better in the end. And so, again, when you do things that others don't want to do, it'll enable you to be able to do things that no one else but you can do. In respiratory care, the nasotracheal tube is most commonly accomplished after an emergency oral endotracheal tube has been placed. The anesthetist now has an unhurried opportunity to choose the largest tube that will comfortably go through the nose. After appropriate anesthesia and vasoconstriction, 1% lidocaine spray and 1/4% neosephrine drops. Very key. The tube is placed through the nose and into the pharynx under direct vision. Both the oral endotracheal tube entering the glottis and the tip of the nasal tube are visualized. With appropriate forceps, The tip of the nasotracheal tube is grasped and steered into the glottis after an aide has removed the oral tube. 1510. In skilled hands, this procedure is accomplished without the patient missing a single breath. The nasotracheal tube is better suited for long term intubation than the oral tube because one, it is easier to stabilize. Two, it is easier to suction. And three, it is safer for equipment attachment. The nasotracheal tube is well lodged within the canal of the nose and can be firmly taped to the nose and face. These factors add great stability and diminish the chances of accidental extubation. The stability also results in less movement of the endotracheal tube with suctioning and ventilation, and therefore less vagal stimulation and better patient comfort. The tube lies firmly along the curvature of the posterior pharyngeal wall and rapidly becomes well tolerated by most patients. Many patients will relate that an appropriately stabilized nasotracheal tube is no more irritating than a nasogastric tube. The distal end of the nasotracheal tube will move with changes in head and neck position, regardless of nose stabilization. Since the patient is constantly being moved and manipulated, one must be aware that there can be significant changes in position of the tip of the tube within the trachea. And here we go, 1510. So, what you have is the nasotracheal intubation by direct vision, and which we just described. All right. Thank you so much for reading with us. Hi, it's Ronald. Let's see. There you go. Clinical application of respiratory care. We're in the second edition by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. We're in the 15th chapter. Hi, it's Heart Love. Thank you for reading with us. Thank you for the likes and subs. I see you guys. Let's see. Hi, it's Heart Love. And here's 1511. As we go in, you'll see A and B. Through the mouth is B, and through the nasal area is A. Says common curvature. A is the nasal tracheal tube, and B, the oral tracheal tube. See text at the top of page 253. All those in the replays and in the playlist. I will get it all together by the end of the book. It will all be in a playlist, so you can just click on the playlist and it'll read the whole entire book, just like the others on this channel. Thank you so much, all the book lovers community. Hi, it's Heart Love. We're doing it. We are doing it. I had a wonderful reading yesterday with the great Tanya Asante. Thank you so much, Tanya. Highest heart love to the King's Gambit, all the room, all the light workers. Appropriate placement is for the tip of the tube to lie in the middle third of the trachea when the head is in a neutral position. This should be documented by listening for bilateral breath sounds with the patient's head both flexed and hyperextended and by chest x-ray. With appropriate placement, there is a little chance that a main stem bronchus intubation or tracheal extubation will occur from changing the patient's position. 1511, which we just looked at, demonstrates the curvature of the endotracheal tube is usually less severe in the nasotracheal tube than in the oral tracheal tube. This lesser degree of curvature usually makes for easier insertion and removal of a suction catheter. The chances of the catheter getting stuck in the tube or requiring a great deal of pushing to pass down the tube are greatly diminished. Facilitation of suctioning means less chance of hypoxemia and other complications. The nasotracheal tube presents certain limitations because of pressure. It is not uncommon for significant pressure necrosis to occur in the area of the ala nasi from pressure of the tube on the skin. Great care must be taken to prevent the tube from exerting undue pressure against the tissue. This is best accomplished by appropriately supporting the attached equipment and tubing. The nasotracheal tube within the nose can totally obstruct the sinus drainage and lead to acute sinusitis. Often the patient is comatose or otherwise unable to complain of headache or pain in the sinus area. The only manifestation of acute sinusitis may be a very high fever. The treatment includes removal of the tube from the side of the nose. The nasotracheal tube may block the opening of the eustachian tube in the nasopharynx. This obstruction may result in a middle ear infection or the otitis media and may lead to a painful earache, fever, and mastoiditis. The external diameter of the nasotracheal tube plays a great role in the potential pressure in the nose. In respiratory care, we advocate using large internal diameter endotracheal tubes to reduce airway resistance during the mechanical and spontaneous ventilation. This should be weighed against the possible trauma that too large a tube will cause in the nose. The thinner the endotracheal tube wall, the more desirable the tube. And we'll pause right here. All right. Yeah. Or keep going. Yeah. Keep going. Okay. Keep going. Here we go. Other limitations of nasotracheal tubes. One, the cough may the cuff may rupture during insertion of the tube through the nose, necessitating reintubation. Two, significant septal deviation is common in adults and can cause an encroachment upon the lumen of the tube, which may not affect ventilation but may well affect the ability to pass a suction catheter. Occasionally, a nasotracheal tube will have to be replaced with an oral tracheal tube so that suctioning can be facilitated because of a deviated septum. Yes. Three, feeding by the oral route is difficult while a nasal tracheal tube is in place, but not impossible. Swallowing water can be a great morale booster to critically ill patient to a critically ill patient and can be accomplished reasonably well with an indwelling nasotracheal tube. Maintenance feeding, however, is poorly tolerated with a nasotracheal tube. Bleeding is seldom a problem during insertion or maintenance, but is often a problem following extubation. Occasionally, a posterior pack may be needed to control bleeding. There we go. We'll pause right there in the middle of the page, 254 in the 15th chapter. Woo! Of clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And I'm your moderator and narrator, Master Uriel Neveu Riley, shaking it up in the world on YouTube, reading books, medical books, right? For the people. Eyes, heart, love. Thank you so much for reading with us. Can't wait till we reconvene with chapter 15, September 22nd. Still under the guise of the new moon. I wish that you had an amazing day yesterday, and today will be even better. Today will be even better. Go out there, shine your light on the world. Know that you are in the midst of greatness. This is the greatest time ever, right now. This time, this day, it's yours. It's all of ours to enjoy together. So go out there, be kind to someone, help someone out, heal the people. That's what I'm going to do. All right, it's heart love. Let's have a glass of love water. Thank you again for the likes and subs. We're pushing towards 1,000 subs on this beautiful, peaceful channel where we read books and learn from masters. I honor you. I honor myself. All the September 22nd birthdays. We love you so much. Happy solar return. Mm. Oh, I love you. 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 That's so good. Wow. Hope the feed is clean. Hope sound is audio is coming through clear. I love you. Thank you so much for being here. All my subs and mods and friends and family. We are doing it, right? You know it. we're gonna do even better next time, right? That's what we learn. That's what I say the other day. When you go out into the world and you see the same things and same people, no, they see you too. It's supposed to be this way. We all win when we live. Times hard. I love you. I love you. You. Because I love me. I love me. Around the ride. Thank you so much. Peace, peace. I will see you soon. That's right. The highest heart love.